So, hello everyone, warm good evening on the finale of the program, the Second International E-Conclave for Oral Cancer. This day we are celebrating a wonderful theme, and we're going to talk about capacity building, how to dethrone that king of all the cancers in the country, the oral cancer, where we have the highest prevalence in the country because of various and multitude of reasons. And we now move on to the next set, yet another mind-boggling session, the panel discussion which we are having for the evening today. So we are going to talk. I have a great discussion with numerous specialists from multi-disciplines for actually discussing from their perspective how can capacity building be done to dethrone the king of all cancers, how the oral oncology connect program from ICanCare can be used to transcend the horizons and bring in new changes, new horizons to treat this disease, to handle this notorious king, and how the oral screening tobacco cessation facilities can help to reach out to the community, whether there is a training need, and how these specialists can actually tame the problem of which is occurring in the oral cancer in the country. So with this, I take this privilege to invite the moderator for this panel discussion for the evening, Dr. SOMESH Chandra sir. He is director of head surgical, director and head of surgical oncology from Sterling Hospital and Sterling Specialty Clinics and Cancer Center. He had been the section editor of Head and Neck IJSO, past associate professor of GCRI, executive committee member of ISO, director of KCHRS Guraj Baroda. He is also the founder executive member of Gujarat Society of Head and Neck Oncology, member of the ethics committee Sterling Hospitals, chairman of Gujarat chapter of Indian Cancer Winners Association, with more than extensive 25 years of experience in oncology and cancer surgery. A versatile and dynamic surgeon himself, has had more than 10,000 surgeries performed and nearly 20,000 procedures done in the surgery over this entire decade. I now invite Sir to please introduce the chairperson and the panelists for the day and take the panel discussion ahead.
Thank you, Shruti. And can you, so uh, Dr. Himanshu would like to make some comments before we start.
Shruti, can you introduce Dr. Himanshu as well?
Yeah, I'll introduce sir first. I'll introduce Himanshu sir. Sir is the director, principal, and professor of head prosthodontic at Seema Dental College and Hospital Rishikesh. Has more than 30 years of extensive academic experience. Fellow of the International College of Dentists, Pierre Fauchard Academy USA, and International College of Continuing Dental Education Asia Pacific. He has more than 200 prolific publications to his name. Currently, member of advisory review board of 14 journals. Delivered 95 keynote guest lectures and conducted 41 workshops and pre-conferences courses at the international and national conferences. Has visited numerous countries as an ambassador of Indian Heritage by Rotary International and also attended various courses. He has been facilitated with numerous awards, which includes the prestigious Appreciation Award for Project Arogya, Free Dental Checkup and Treatment Camps 2018 by then Vice President of India during the 11th International Dental Students and 5th Dental Surgeons Conference in New Delhi. He has also won the Research Peace Award 2019 for International Best Researcher in Prosthodontics and Oral Implantology. A versatile principal and dynamic person himself, we invite Sir to have a few words before Somesha takes on the panel discussion ahead.
Thank you, Dr. Shruti, for such a nice introduction. I'm listening to this program since last 1.5 hours, and I'm really delighted to be part of it. And the lecture given by Dr. Kastov, Dr. Anil, and Dr. Puneet was excellent. And we have to do a lot of work in the field of awareness of oral cancer and how to control tobacco. And as everyone told, private organizations and NGOs are working hard. But the main push will come when Government of India will join hands with us. As Dr. Swatan told very rightly, Dental Council of India has make it mandatory to make a tobacco cessation clinic, but it should be functional. It should be fully functional. And our India mostly live in the rural area, so and most of the cancer sufferers are from lower socioeconomic group and living in the rural area. So we have to focus on these areas. So these are my suggestions, and I hope with this panel discussion under the guidance of Dr. Somesh Chandra, we will learn something and we will be able to contribute something to the society for this awareness.
Sir, you're on mute. Somesh, sir, you're on mute.
Thank you, sir, for your comments. And let's get on with the job. We had three very important lectures with important takeaways by three luminaries who are working to dethrone the cancer and connect the oral oncology program, who are involved in teaching and training and the fight against oral cancer. But as they say, a lone sparrow does not make a spring. And nonetheless, so we'll have some takeaways from all the three lectures. The idea of merging the zone of control with the zone of influence from Dr. Kostup's lecture, and how to win after losing on previous occasions from Dr. Pawan's lecture, how to build a program and how to succeed on that. And a lot of takeaways from Dr. D'Cruz's program, lecture. Two important points there where 80% come at advanced stages, and it's largely because of delayed diagnosis. Let me first invite my panelists. Dr. Rakesh Rawal is a professor of Life Sciences, Department of Life Sciences, Gujarat University. I can see him there. Dr. Arun Balaji is the section lead, speech and swallowing therapist, Department of Head and Neck Oncology, TMC, Mumbai. Dr. Asif Ahmed, who is a consultant in dental oncology and maxillofacial prosthesis. Dr. Aneri Shah, certified clinical psycho-oncologist, HCG Cancer Center, Ahmedabad. Dr. Manjusha Wagal, I hope I got that pronunciation correct, who is the professor and officer in charge at TMH in occupational therapy, and Mrs. Shruti, who is our host for the entire program and very energetic and very knowledgeable on how to conduct successful program, and who's along with Mr. Rishabh, the backbone of ICanCare, I would say. Dr. J.K. Gupta, who is a dental surgeon, and Dr. Surendra Senapati, who joins us as a radiation oncologist. So welcome all panelists. I additionally invite Dr. D'Cruz to be on the panel. We have one missing panelist, Dr. Gauravi Mishra from Preventing Oncology, but I think Dr. D'Cruz can more than fill up the void created by her absence. Dr. D'Cruz, are you there? He'll join in some time. The five main issues were already highlighted by the organizing committee in the brochure. The first was capacity building to dethrone the king of all cancers. And we'll start with that. I feel that oral cancer is just a mask, and the king is really not oral cancer, because a lot of other cancers, say lung, you would see figuring at number 2 or 3 in most of the cancer list incidents. So it's just a mask, and the real king is tobacco usage. And I have some data on tobacco usage. According to the Global Adult Tobacco Survey, GATS, conducted in 2016-17, the overall prevalence of smoking tobacco use was 10.38%, and smokeless tobacco use was 21.38% in India. And that largely, I would say, accounts for the huge difference between the incidence of oral cancer, which is the Indian cancer, the number 1 in males and number 4 or 5 in females, compared to lung and other cancers which are linked with with smoking tobacco. And on that count, I have some questions for our panelists. Uh, just We've seen that a lot of efforts are being made. UICC, on its head, is the largest NGO working against cancer. And in India also, we have the National Tobacco Control Program. We have the NCCP running for the past 30 years. Uh, I want to ask my panelists in that order, Dr. Aneri and Dr. Vagal to start with. What are the barriers to success of these programs? Is it because we have not defined endpoints? We have left them on an endless path and we have no definite goals to achieve. That we need to bring down the mortality by so much percent, or the detection rates to be going up by so much. So do we lack an endpoint? Is it one of the barriers to success of these programs? Are we working? Is it because we are working in isolation rather than in collaboration? Like Dr. Pawan said, someone who comes in with an MI goes away with a stent or a CABG without addressing the basic cause. So we seem to be working in isolation. That's one of the reasons I see. And do our present actions yield results which we see immediately in the next 5 years or 10 years? Or is it really working for the future generation, which is going to be more productive? Australia, we know, has recently embarked on a program not to have any tobacco sale or use by its adolescents and young adults. So we must have some timelines. We must have a horizon on where we are going. And to start the talk, I invite Dr. Aneri and Dr. Vagal in that order, and others can pitch in with their thoughts.
Sir, Dr. Aneri is currently unavailable. She's stuck at the airport. So we'll begin with Manjusha, ma'am.
Yeah, Dr. Manjusha, please.
So actually speaking, I'm an occupational therapist. And I think the right person to comment on or give information on this is from the preventive oncology. But still, what I feel is we need to do a lot. Whatever is being done, as you rightly said, doctor, we are doing in isolation. Dr. Pawan Gupta, as I know, I met him in on his one of his visits at TMH Hospital some 8-9 years back, when he had come to our department and visited us. That time I had a word with him and I understood that he had a lot of plans for tobacco prevention and working on head and neck cancers. So I think we need to do a lot. And as an OT, I think it's more of the rehab perspective when the patient is being treated, or as we can intervene for their prehabilitation when the patient is about to receive the treatment. So prehabilitation is very, very important for this patient to prevent the potential side effects of tobacco and the treatment and the diagnosis. But yes, we need to do a lot. As an OT, if you ask me, we are into education of the students at graduation level. So in the graduation level, if we emphasize on this part, tobacco, and have this as a part of our curriculum, probably this will add to the advantage of the public by and large. And of course, professionals will get more insight into the side effects of tobacco and all.
Madam, do you have in mind any particular occupational groups who need to be targeted? Seeing reports that people who are idle at one place, whether it's a driver or a liftman or a clerk, they are the ones who are more likely to be using smokeless tobacco. For smoking, people generally are now required to go out because of the norms of the offices and public places. But smokeless tobacco, and we know that the duration of exposure to smokeless tobacco is an important factor in causation of cancer. So, would you like to target these special occupation because they also belong to the middle and poorer class,
Yes,
which
yes,
account
yes.
for the larger number of oral cancer cases?
Yes, definitely. Sir, I had recently visited Silchar, the Kachar Cancer Hospital, and that's the first time I understood that many of the patients have head and neck cancer there, and it is because that is their occupation. Like a lot of tobacco plants or betel nuts I mean, they are growing that. That is the farming that is happening there, and people are into habit of eating betel nuts and tobacco there. So definitely, the low socioeconomic strata, as we know, the statistics also suggest the low economic strata is more into this habit of consuming tobacco. So we need to educate them definitely.
May I ask Dr. Surendra Sinapati? Is he there?
No, sir, he's also not able to join. Dr. J.K. Gupta and
Okay,
Dr. Surendra Sinapati.
Dr. Gupta, an important part of the data which we discovered why oral cancer reigns as the king is that we have late diagnosis, and there's a delay of 6 to 7 months. Is it on part of the physician or is it in part of the patient reporting late?
In place of J.K. Gupta, can we ask Rakesh Gupta to answer? Dr. Rakesh Gupta, if you are there. Yeah.
Yeah, Dr. Rakesh Gupta, please. So this delay, I wanted Dr. Gupta, if you could highlight, is it primarily on part of the patient in reporting to the doctor, or is it on part of the physician being unable to diagnose or spot cancer early enough?
Good afternoon all, and rather good evening. And I actually joined late, but I can just enlist the reasons why we have not been successful in controlling tobacco. So I think I can do that better. So one thing is that there has not been talked about IC and awareness activities, and it has been done enough in the last maybe 15-20 years. This has been done enough. So not many patients, you can say, they don't know about the harms of the tobacco. So as earlier said, that the smokeless tobacco is the main culprit in Indian context, because we are talking about the cancers of the head and neck, oral cancers, and SLT is the main culprit in that. So we should now start, actually Government of India and all the states, they should now start implementing the COT Pact and all related act, especially the SLT has been banned under FSSAI, right? So that should be strictly implemented. The ban should be implemented strictly. The spitting should be banned.
Yeah,
so,
but may I interrupt? See, we know that the control lies with the government to ban. But the area of influence lies outside the government. So we have at least 12 to 14 to 15 states which have banned the manufacture and sale of these gutkhas.
Right.
But it goes on unabated.
Yes.
So as a say a social group, a medical social group, a healthy social group, how do we try and influence? Like we have these Lok Rakshak Dal, which are not really the police department, but they are brought up from the society to look after some petty crimes. So is it time that we need to develop these groups, say in medical colleges or in large hospitals, from their own staff, from their students, from their interns?
Right.
Is it important to do that? Because we know that at least opportunistic screening is an essential part of targeting the high risk group, which is going to be the most beneficial.
Yeah, you're right that way. I mean, opportunistic screening that has to be done regularly. and in all the states. But the thing is, I'll come again to that, that unless the strict implementation of the acts, already available acts, that is done, people, they don't listen to it. They people are already aware about the harmful effects, and organizations like Dr. Pawan Gupta's ICanCare, they are doing a lot, and they have created a lot of tobacco marshals. So they are doing a good job. But still, I feel that the government has to act. And another thing is the celebrities. Now they are doing surrogate ads. So recently, you might have heard about the Akshay Kumar, Amitabh Bachchan, then Jackie Shroff, and Ajay Devgan. They're all celebrities. They are doing ads for these flavored, so-called flavored elachis. But in fact, they are advertising for pan masala and gutka. As we all know, the gutka may not be available, but the pan masala, when mixed with tobacco, that becomes gutka. And so these celebrities, they have also been requested in recent days, in last 7-10 days. We have been acting on that issue also. We have been requesting celebrities and also asking MOHFW to make sure that surrogate ads are not done. So I think, yeah.
I'd like to point out here that on paper, at least, we have an organization which has been working for at least 12 years, the NPCDCS.
Yeah.
I tried to look into the structure of NPCDCS, and it's more of an administrative structure. 2 days back in the Times of India in Ahmedabad, I read a news item that a nephrologist has been put on the panel of NPCDCS. As yet, I have not found a single oncologist on the panel of NPCDCS, because cancer, other than dental, oral, and maxillofacial surgeons, is a great concern for all oncologists.
Right.
I see that there are some people from PSM, preventive and social medicine, and oral maxillofacial specialties in the NPCDCS. But there is nothing from the oncology group to influence the working or to define targets. Like I said, and I would like to ask maybe Dr. Rasif, Dr. Kaustubh is there, if Anil is there, I would like you to pitch it. That is it because we lack definitive targets that in the next 10 years, we need to bring down the mortality by so many percentage points, or we need to screen so many people in each organization. You just need to screen, you just bring out the figures. And the government has launched on a digital health mission. It's very easy to put things on their digital cards, the health cards which they have. So are we not using technology well enough? We have, Dr. Pawan might remember, tried on a very small scale when we launched the Swasth Network and eSwasth for telescreening, but we failed utterly, largely because of lack of funds. But the government is a very big organization, and we have lots of dental associations and oral maxillofacial associations. We have premier institutes like the Tata Memorial, and we have large oncology care corporate setups like HCG. Why can't we pitch in to help the government define how really we can make a difference rather than just doing it on paper? Because we also have a national tobacco control program, which apparently has not delivered. Dr. Kaustubh, would you like to make a comment on that?
Yes, so let me start with something which is very paramount for any MBA studies. Unless you have targets, you will never achieve your goals. This is very important. What SOMESH said is a very important factor which decides the progress. Whenever there is any program, there has to be endpoints. The defined endpoints needs to be there whenever you define policies. So once it is not there, then everybody is working on their own agendas and on their own progress. If there is a goal, then only we will be able to define whether we have achieved it or not, whether we have achieved 50%, whether we have achieved 25%, and then the reasons why we could not achieve it, and then correct it. The path can be corrected. So, Somesh, that is very important, and probably that is why in my presentation there was a slide which said that we must have political and opportunistic capacities. So these kind of organizations needs people like the people on this board, on this this conference. If they are there, they will be able to influence the policies and guide them. So when Somesh says that a nephrologist is on the panel, I feel so bad that an oncologist has to be there in the panel, but it's not there.
And the name of the organization is NPCDCS, that's Control for Cancer, Cardiac and Pulmonary Diseases, and these are all preventable diseases. Nephrology and kidney disease are end and secondary disease. Dr. Rakesh, we found in the earlier talks that the age at which people take up tobacco is about 18 years. You are working at the university. Can we, I mean, we have a lot of talk going up on that the IIM has included Bhagavad Gita in its curriculum. And we have so many school textbooks designed by NCERT being modified to suit different important or perceived as important aspects of education. Shouldn't we educate people about this epidemic of tobacco in youngsters, tobacco use? You'll have to unmute.
Yeah. So, as Dr. De Cruz rightly said, that the initial age is somewhere around 18. So, either when they are leaving the school or when they are entering into college, possibly there should be a part on this tobacco addiction and its ill effects on health as a part of curriculum. So, what we have initiated in Gujarat University from the School of Indic Studies, so a healthy lifestyle course is initiated, and that is compulsory for all newcomers. So whenever the student enters into the 5-year integrated courses, one of that will be the Indian traditional lifestyle and the healthy good habits which will make them healthy. So part of that also includes the tobacco and its ill effect. So I think that should be adopted by many other organizations and colleges, because that is the right time to hit. Because once they enter into college, they have got more freedom, because in school it is still restricted to the institution and still under parental influence. But when they enter into college, they get peer influence and they start these habits. Yeah, so we should start with this.
Yeah, so I would suggest that along with the tobacco cessation training program certification course that we have at GU, we write to NCERT as well from ICanCare. Dr. Pawan is listening intently, and we try and approach more universities to include this as part of the curriculum as.
So it has to be implemented through UGC. Then every university will adopt that.
Okay.
So that will be the right way to enter into academic institutions.
But it has to begin from schooling level.
Yeah.
I think schooling is very, very important.
Coming
As
back
we talk about sex education and all in the schools, you know, this should also be an important part to be included in schooling.
Yeah, because we are looking at it from the oncologic point of view.
Correct.
But tobacco has a lot of effects. It affects fertility. It affects the look and beauty. And we must remember that at least 10%, more than 10% of Indian females are currently tobacco users. And especially use of smokeless tobacco is pretty high in women as well. So I think we need to work on these points. Moving on, I would like Dr. Asif to comment on this first. The Oral Oncology Connect program, because we saw that oral cancers are not only being treated late, but they are being treated in bits and pieces. So we the 30%, the 20 to 50% cure doesn't translate into good quality of life. I call this, we do run something to that effect, and we call it the life-saving, face-saving program. Because these people are, even though saved from death, they are not saved from a social death. So how would you look upon the Oral Oncology Connect program, and what are your views on expanding the horizons and how to involve people?
Good evening all. So in my institution, that is in Tata Medical Center, Kolkata, we see the major chunk of our patients from head and neck oncology and plastic department. So it's the oral cancer patients that are mostly come to us. So as Dr. Anil sir said, regarding the every institution are now having that DCI has made it mandatory for oral tobacco cessation program for every institution. I believe DCI should also make an oral oncology subject as mandatory for their curriculum also. So the BDS or the MDS students should know about or learn about oral oncology, and that can again help them because all are not connected to the cancer institutes. So even in the private practices or even in their other institutions where they work, they can implement and do the oral screening much better than without any training of oral oncology.
Yeah, like there is a program in oral pathology. So I think that it's appropriate that we must have a program on oral oncology. In the city of Ahmedabad, it might interest you. We have at least 35 oncology training programs, MCH, DM, MD, and DNB going on. They are largely broad-based. They cover surgical oncology. There is a single program on organic oncology. Few centers have come up with head and neck oncology programs. Do you feel that giving up on general surgical oncology training and focusing more on specialized areas like head and neck oncology would be more fruitful, would serve the community better?
Specialized training, I believe, is all the time better than going with the mass or general screening. So I believe, yes, specific training are more helpful in such screenings camps.
Yeah, so we'll discuss that a little more when we come to the last part, training. Anyone in this panel would like to comment on is it possible to build a model program for oral oncology, oral cancer care, or head and neck oncology, which the program essentially needs to have a multidisciplinary inclusion. So we are not talking about a surgeon, we are not talking about just a radiation oncologist. We must remember that a lot of these patients are nutritionally depleted, which works both ways. It works in causation of cancer and works towards poorer results. Many of them may not be able to complete treatment, they lose weight. We have prosthodontics, we have prosthesis, which is a largely neglected branch So nutritionists, reconstructive surgeons, prosthodontists, maxillofacial surgeons, uh, and each of these centers which are dealing in oncology should try and have a preventive oncology and a tumor registry program. Would you agree to that? And I mean, is it good that we build a model and then it can be presented for duplication?
This is for me, sir.
Yes, because you are working at one of the leading cancer centers in India.
Yes, sir. I believe it's a teamwork. First, we should build up a teamwork, and then make a model for it, and that we can get an example, because it's not a one man, like only one person can't do everything. So we need a head and neck oncology, the radiation team, the plastic team, the speech and swallow therapist, the prosthodontist, and it should and the dental oncologist also. And then we should build a team, and that makes a proper model for to show as an example, and that can be called an Indian model.
Dr. Balaji, I would like you to add considerably on that thought, because, like I said, we make patients oral cripples even though we have saved their lives, and I'd like to highlight the important parts of maxillofacial reconstruction and rehabilitation.
Definitely, comprehensive cancer care is a basic requirement for every patient that we treat for cancer management. When we talk about oral cancer, we always talk about post-surgery sequelae and post-surgery morbidities. But we need to understand that baseline functional evaluation is very, very essential. We are not going to see as everyone's rightly said, most of our patients are advanced oral cancer. So when you evaluate baseline, they will be eating only liquid food or soft food consistency. They are not going to eat every food consistencies because of the tumor, such as in the tongue. Patient who comes with a huge tongue lesion, they will be having a lot of difficulties in eating normal food consistency even prior to the surgery. So evaluation should start from the prior surgery and after surgery, and we need to make sure to the patient as well as caregiver about what are all the challenges the patient is going to face post surgery, and we should not make the patient panic. And we have to tell about our facilities and what kind of rehabilitation that we are going to offer, and continuing of rehabilitation during radiation therapy is one of the key for successful giving quality of life. Because in many centers, as we know that there are 27 regional cancer centers and national comprehensive cancer grid, in there are more than 200 plus cancer hospitals are there, but the rehabilitation specialists are very, very less. That makes it challenging to rehabilitate these patients. So definitely comprehensive cancer care is very, very essential to mitigate the problems.
If I may add to that, when we talk about speech therapists, I have till date not been able to locate one which who can address the special speech disabilities faced by a head and neck cancer patient, because most of them are related to voice therapy rather than speech therapy. And a lot of speech is affected by treatment of oral tongue, which is one of the leading causes of cancer. And we really have no one to address that specific need. The so-called speech therapists who work with otolaryngologists are basically voice therapists and not speech therapists. So do you have at any of the centers in India, are you aware that we have any training programs specifically addressing this need, and how to develop? What would your suggestions be on how to develop this?
I totally understand your point, saying that all speech therapists are not competent in treating this head and neck cancer rehabilitation, because our course curriculum did not focus majorly on this. But we at Tata Memorial Hospital, with collaborating with Diku sir in 2018, we started a fellowship program for master degree speech language therapist. It's a 1-year program. So till now we have completed 3 batches. And our future goal is to start MSc speech pathology for head and neck oncology rehabilitation. So that is one of the major thing we can develop human resource in this kind of rehabilitation program. And certainly we need to think about a PhD program as well, majorly focusing on oral cancer, laryngeal cancer, hypopharyngeal cancer as well. So training programs very, very essential. As of now, there are very few training programs are available, especially for head and neck oncology rehabilitation. I'm sure in future more and more training programs will be available, and we need to work.
I'll take this opportunity today, and Dr. Pawan, I propose that we make a request to Dr. Balaji's unit at Tata Memorial to have at least observers from various places, so that it is this expertise is, at least some of this expertise can be disseminated more widely throughout the country. So I propose that you think about starting an observership at least, or a short fellowship program over and above your core curriculum.
Sir, I would like to add here.
Yes.
Sir, I would like to add here. Since you are emphasizing on speech, it is definitely required. Most of our patients, and I see how Dr. Balaji is working extended hours is working there. But the patients have many more rehabilitation needs. So as I think Dr. Pawan has already emphasized on trismus, and he has developed something to address the trismus. The patients also have head and neck lymphedema, which is very much ignored and not given much attention to. Then shoulder and neck dysfunction, fatigue, intimacy, sleep problems are there. They are in need of rehabilitation. So you need to actually see the person as a whole, and not just one aspect should be emphasized on. So at TMH, we are working a lot for these patients towards rehab. So if they starting observership, let their observers visit the occupational therapy department as well. So that will benefit the patients at large for many patients in different institutes in our country.
Thank you, Dr. Manjusha, for that excellent offering. And I think Dr. Pawan would have made a note of it, and we should start working on combined observership in occupational therapy and speech therapy at TMH, building a program through ICanCare. Moving on to the next point, oral screening, tobacco cessation, and how to reach up to the community. I remember that about 5 years back, during one of our cancer screening camps at one of the public setups, we screened 117 individuals, and I have some data. Just let me check that. So I thought that this data was very important, and I contacted the local leading daily here because the data is like this. We actually measured their mouth opening. In a screening of 117 subjects, approximately 97% males, 52% were users of tobacco and or gutka. Amongst the non-users, the mouth opening was just as adequate, that's more than 30 millimeters, in 95%. But in the group with 5 years or more of tobacco gutka consumption, only 2.5% had mouth opening, adequate mouth opening, that's more than 30 millimeters. In fact, about 13% of users had less than 1 centimeter of mouth opening. Obviously, these are not data which are published from a very famous source, or these are not data which would astound the normal public. They do not understand the significance of a reduced mouth opening and what it points to, and what is in store for these people in the few years down the line. So oral cancer screening, when we do, if we look at again the NPCDCS website, it talks about early warning signs of cancer. I mean, these are all telltale signs of either a pre-malignant condition or even an advanced cancer, which are ignored. So building up a effective screening program at the ground level, they have an ASHA worker working as the last point of contact with the community, and that ASHA worker may or may not himself or herself be a tobacco user. Like Dr. Pawan showed, if practiced properly, there is more than 90% success rate in tobacco cessation, and cancer screening would still be higher. So, can we adopt these kinds of models more widely at institutions across the country? If we cannot go to the community, because going to the community is largely the purview of the government or large NGOs, which we lack because of lack of staffing, lack of funding, and lack of interest by people who influence the social minds, the media. So do you have any suggestions for going to the media? And how do we influence that? Because as clinicians, we are daily engaged in our own clinical work. Dr. Asif, would you like to address that?
Going to the media, yes, we can do it, but how do we do it? We really don't know. I really don't know from my perspective. Because being a clinician and full-time clinician and a post-odontist in Tata, going to event, you need an event management or event manager for getting that, doing so. So my personal, I don't have any experience in such.
So Shruti, you know that you are working with Dr. Pawan and now even listening to Dr. Asif, that if you really want to broaden your footprints in the community about screening and tobacco cessation, you have to look beyond clinicians. How do you propose to do that?
Third, one is definitely having a public figure, someone who has actually quit smoking or tobacco, or maybe at least one public figure whom the people can resonate their thoughts to. When someone can follow Jay Devgan or Akshay or anybody as the role models and take up liking those products, I'm sure with a strong and staunch message. When Akshay Kumar came down with a beautiful ad on traffic control policies, I'm sure that one keen message from a very good public figure can really bring and divert thoughts from the community, from everyone to start thinking about it. And clinicians, of course, also have a role, because it is the ultimate place where the patients come in. And when the patients come in, education, which also Anil sir had said earlier, that education to those patients on these aspects of early screening, diagnosis, and then influencing and taking it ahead, propagating it ahead is also very important. So I think that both clinicians have a role, a public figure also has a role, and also we have a tobacco marshals program. So these tobacco marshals are actually the influencers from Gram Panchayat, from rural areas, from social clubs, from districts, from tier 2, tier 3 cities, who are who are key decision makers and also influencers for policy making. These can bring about changes. These can add on to the kind of awareness we want to bring in, the kind of awareness we want to pitch in the community. So they can really create a rage fire and bring that difference. That is how I feel.
How do you motivate these people to do their job?
So the best motivation is something they're gaining happiness. I think the one thing which we have found is seeing happiness or saving one's life gives more happiness than actually earning a lot, or maybe doing something where I'm spending a hell lot of amount of money. So this is one factor which we have actually identified from ground, that saving one's life and taking that pride in believing that yes, I've helped someone, I've done something, I've given back something to the society, is the key motivating factor for these individuals, and that's what we have been doing at ICanCare.
We were at some point we had tried to calculate how much, or rather, many times they have done this exercise, explaining to patients how much they have spent on tobacco, and now they want a free treatment.
Yeah. Sir,
Right. And this free treatment, if it is not available, they would get it through a health insurance. And the health insurance companies would ask if there is a history of tobacco use. And if there is a history of tobacco use, they would deny the Mediclaim.
yeah.
So, demotivation that you may be denied an insurance claim for any disease, for any treatment, whether it's CABG or a cardiac stenting, if this thing comes out, can that be a motivation for people to give up tobacco?
Absolutely, sir. I would definitely agree to it. And we have been trying to push that agenda with the insurance companies and also with the healthcare professionals across the country. Wherever we are meeting, we are trying to create this awareness that there has to be, at least in the form of color code or something has to be given so that the person clearly declares himself or themselves, or at least the professional declares that this patient is a tobacco user. I mean, it's very sad that the current state of affairs in the country is not, so we're not very practical. We are helping the patient in every possible way to seek those claims by forging and not saying that that person is a tobacco user or a smoker. But we really want to push that. And I am always, we as a team are always looking out to those solutions, how we can really change this mindset. It's a tough job. It's a mammoth task to bring that mindset change. So this is something where I look forward for everyone's idea and brainstorm to see and deliberate how we can bring that change.
Dr. Asif and maybe Dr. Himanshu, do you get such queries from health insurance companies asking and denying them, and how do you deal with that? And is the way we deal with it, most often we deny it, is that the right way forward? Are we helping the cause, or are we defeating the cause?
Well, I would like to add, for
Yes, sir.
this early diagnosis or early detection, we should train our young graduates, whether it is dental surgeon or medical people, those who are dealing with the community. The patient is coming to them and they can diagnose it at early stage. So there is no need of extra training for them because they are being taught all oral pathology, oral medicine, and what are the signs and symptoms of oral cancer. So whenever a patient is visiting some doctor, and if he finds some early signs of cancer, so it is the duty of that treating doctor. He should tell patient and he should refer it to the proper oncologist. This is regarding early diagnosis of the cancer, and this will be a great help. And regarding creating the awareness, sir, I will like to emphasize, because we have to create awareness to the young people as I are discussing. So as we are discussing about the celebrities' role, if you see nowadays IPL is going on, and every youngster is watching it. So we can make slides, what are the pre-cancerous lesions or what are the signs of pre-cancers. So they can be publicized through these kind of TV shows or this games during the game. So that will create the awareness, what are the signs. Because everybody is aware for good health. Nobody wants to die, nobody wants to suffer. So if we give them what are the signs and symptoms, what are the early signs, as you said about the mouth opening, we have done some survey of mouth opening. So literally we can tell them if your mouth opening is reduced, if you are having some non-healing ulcer in your mouth, so then you should report to the doctor, dental surgeon or oral surgeon. So this kind of awareness we should create.
Can we have some more opinions in this? Say Dr. Manju Jain and Dr. Rakesh. Yeah, please.
So if we see, usually whenever we are filling a medical form for medical insurance, it is usually first-hand information. So many a times we don't reveal the habit that is there. But if we include that as a criteria, say height, weight, everything, then amount of mouth opening, so in terms of say millimeters, so that is an indirect measurement. Or a point of care device, that is say a drop of saliva can detect the nicotine cotinine level, because if that becomes mandatory, and that is useful to the insurance company also, because ultimately it is useful to them for deciding the premium. So those are such point of care device, so that can be handled by even the agent who is visiting the patient or the insurance taker. So these are small criteria which can initiate on a longer run, because then people get aware. Now your mouth opening is also one of the criteria. And for media presence, I would say that in local newspaper, usually there is a health column in majority of cases. So in that, if you voluntarily participate and focus on such writing, or as ICanCare has introduced, a medical cartoon, a cartoon character which continues for a week or something, so that because people follow the purtis of the local newspapers, and usually housewives are more onto that. So I think that is one area which can be sensitized, because the housewife is the center of managing the health and everything of that family. So these two.
Yeah, so those are good suggestions, Rakesh. The only thing is that media follows funds. It sniffs at funds, and it would only take up what is funded most of the time. Dr. Manju, you had something to say. Dr. Manju Jain. You'll have to unmute yourself.
So good evening, everybody. I'm from your field. I'm a very different. I'm just a psycho-oncologist, and I've given presentation in American Psycho-Oncology World Congress, Washington DC, and Psycho-Oncology World Congress Dublin as preventive medicine, and in Portugal. So I've been working with Dr. Ajay Mehta, the oncologist in Nagpur since 2009. And with the help of Dental College Dean, I was working on submucous fibrosis. And there was a patient whose mouth opening was just 25 mm. And sir introduced me to the patients and said, you can take up your research. And I just taught them those mantras. And he was a very young boy. And when everything was over, all the doctors were there. And after teaching, the dean asked me how much time it will take. And I said 21 days. Then he came and advised me that it takes 6 months for 1 mm opening to increase. How will you be able to do within 21 days? And I just told that boy, now there's no harm in chanting. You can just keep on chanting and we will come back after 21 days to this medical college. And then we came back, and when he went to get it measured, his mouth opening had gone up to 30 mm. And they were really surprised. And now his mouth opening has come up to 37 mm. Just by listening to the chant, and he's a Ramesh Sahu. So his case study, 2 of them, this just now I paid one more case study. This was Gunath Sambhalkar, whose voice had totally gone. And my Integrated Healing Forum president, who was principal, Janet National School, he said, out of the 2, even if you get 1 patient healed, I will understand your research. And I was working every day with this patient, and he did not have voice. And he was just chanting with me in his mind, and his wife was also doing that. And after 21 days, he started talking. And when I heard this, I said, you can speak now. And I took him immediately to oncologist Dr. Ajay Mehta, who's in Nagpur, HGNRI, if you must if you know him, he is special breast cancer. And he immediately did endoscopy. He showed me even the rise inside, and he gave me immediately endoscopy report. And he said there are no cancerous nodules in his this thing. And he said, you keep this. Didn't even charge me. He said, you are doing such good work. So like
Thank
this,
you, Dr. Manju.
And I got a.
Thank you, Dr. Manju, and I'm sure those case reports are very interesting, and maybe someone at Tata Memorial, when they launch an integrated healing program, they would look into it. I would like to move on to the last 2 points which were mentioned to be discussed: fishing or feeding, and the need for training. I think they can be clubbed together. Uh, when a dental surgeon or an oral max surgeon is extending support to an oncologist, or an oncologist extends a hand to a dental surgeon or oral max surgeon, how is it looked upon? Is it looked upon as fishing, uh, or is it looked upon as actually hand holding? So is it a doctor centric activity, or is it a patient centric activity? I have come to believe that at the best centers, we have a science centric treatment paradigm. At many other places, we have been accused of having a doctor centric treatment paradigm. But I'm sorry to say that I have come to realize that we hardly ever have a patient centric treatment paradigm. Because if we do that, these questions would not arise at all. And from that, I would move on to asking about how do you develop a training program. Dr. Anil said that specialty programs are very important. They have been shown that they yield results. So treating is not enough. You have to treat them right. There was an entire edition of EGSO, European Journal of Surgical Oncology, which addressed what was more important. Was it numbers or was it training? Obviously, both are important. You need to have adequate numbers to get adequately trained, but the quality of training is definitely more important. So, when you extend a hand, uh, is it to offer your services, or is it to gain something from the other? So, is it right for a dental surgeon to extend into the field of oncologic resections without proper training, without understanding the science of oncology? We as oncologists understand that oral cancers are far more sinister than, say, a breast cancer by and large, or a colorectal cancer. They are very fast growing cancers, and they would punish you with a recurrence and death very soon, not 5 years, 10 years down the line. So I would start off with Dr. Asif. I would come to maybe if Anil is there, I'll come to Dr. Anil and Dr. Costa, who are all running training programs. And how do you look upon this association with different specialities? Is it fishing? Is it feeding? And how do you do that? Because it said that if you give a patient a fish, you feed them for a day, but you teach them fishing, you feed them for a lifetime. Dr. Asif, to start with you.
Thank you, sir. So in this, I would like to say that we should always be trained before we touch the patient, not only doing a surgery, even by giving a medicine also. So you should be trained first, and when you're trained, so in Tata Medical, what we do is we offer trainings like training programs like Prayash, TMC Eco, which is done on Saturdays, and it's mainly targeted to the BDS students or the Ayush doctors, where we teach them regarding the screening part, all oral screening, cervical screening, gynecological screening, all of the screenings are taught over there. Then we have observerships, as Mr. Balaji has already informed regarding that. Observerships are very much important. They come to know what is oncology, how do we deal with oncology patients, what are the different aspects of oncology. So training is definitely is never a doctor centric, but yes, it helps the patient as a whole, not only in the institutes but also wherever they go and practice their specialties.
So do they come to you trying to learn a resection so that they can do it on their own, or they try to learn that when a resection is done, before, during, and after that, what is their role as a dentist? Because that message is very important.
Sorry. So first to diagnose it. What is it? What we are dealing with? Is it a cancer? And if it's a cancer, and how do we approach the patient? First, the approach is important. Once that is dealt with, Then yes, the resection part, but being my prosthetist by myself, we deal with the prosthesis part, the silicons, the extraoral or the implants in fibula or in any other, in a normal alveolar bone also. So this is how we teach them that where you have to put implants, where you can't go in for implants, the different stages of ORN or Monge, different things that can happen if you do extraction in the bisphosphonates, what are we going to make the patient suffer from? So these are the trainings that are required in what you teach them.
Right. Dr. Costa, we would like to add to that. You'll have to unmute yourself.
Yeah, Somesh, this is a very important point, and I have some thoughts. Before about 5 or 6 years, we could find that there are lots of maxillofacial surgeons operating on head and neck cancer patients, and then we had a lot of adverse outcomes. Now we realized that there's no point in telling anybody not to do something. The right thing is to tell them how to do it. That is the most important thing a trainer or a leader should understand. So the first point was to start training properly the oral oncology. Now, what happens is that in the many of the dental colleges where this is being taught, the surgical oncology angle is lacking. And that is the reason why there are lots of issues with this training. So we at Foundation for Head and Neck Oncology, when I was president, we took a challenge and we devised a curriculum on oral oncology for maxillofacial surgeons. And this fellowship is 2-year fellowship, institutional fellowship. We started all across India, and now there are 32 institutes. These institutes are cancer centers, and they give training to maxillofacial surgeons to become oral oncology certified by FHNO. So this kind of a precise institutional training is required to then start offering these kind of surgical or treatment modalities to the cancer patients across society. So the maxillofacial surgeons should understand that they need training. The surgical oncologist must understand that we are not enough. If you have gone through my lecture, you must have understood that what kind of an oral cancer epidemic is going to come, and there are not enough specialists to treat these patients properly. So all of us should focus on training more and more people into the right way to treat this disease. And that is what, and this fellowship, just for your information, is there is an entrance exam and there is an exit exam. And once you pass that exit exam, then only you are given the certificate. So it's a stringent kind of a curriculum. And if these kind of programs are done more and more at more and more centers, probably we will have properly trained maxillofacial surgeons working into community, giving good results. Except this, if they are not well trained, I think at college level, they must understand that their role is to detect early. Their role is to biopsy, to diagnose early. Their role is to rehabilitate them properly post-treatment. Their role is to support oral surgeon, oral surgical oncologist peri-operatively for prosthodontist and other dental rehabilitation issues, as well as mandibular reconstruction, where their expertise of plating and screwing and making mandible, the reconstructive aspects better. These are all the issues which they are supposed to add into as an expert. But if they want to do a resection, then I think these kind of proper training is a must. Otherwise, it will be not fruitful for the society.
Thank you for those very incisive comments, because before you dissect, you need to understand the disease, you need to understand what kind of radiology to do, and all those things. So there are various elements of a training program which a good center would adhere to. Before winding up, and this could be the last comments, I would invite from Dr. Himanshu and Dr. Rakesh Gupta, if he's there, that in your busy dental practices, wherein oral cancer is a small number, would form a small number of patients that you see, how easy is it to miss one, and how do you devise a plan not to miss those infrequent encounters with oral cancers, and what would your suggestions be to all the dental practitioners on how to set up a opportunistic screening program for oral cancers?
As I told you earlier, I will like to say because I totally agree with Dr. Kostov. The role of dental surgeon is not in curing or resection of the cancer, because that is a specialized job and we need team of the people. In most of the hospitals, good hospitals, we have tumor board. The role of dental surgeons may be there and is there to diagnose. As we are discussing, early diagnosis is very good. We can prevent the loss of structure if we have diagnosed it at early stage. And in this role of dental surgeon, whether it is a conservative dentist, orthodontist, prosthodontist, he is seeing oral cavity as a whole. And all dental students are being taught as per DCI curriculum, and they know early signs of oral cancer. There is no need to further training for early sign of oral cancer. So their role is very crucial. They can identify the oral cancer, and without any agitation, they should refer it to the concerned specialist. That is the first very important role of dental surgeon, and they should play very important role in this. Another thing is screening. As we are discussing, we are organizing lot of dental awareness camp. Last day only I finished a camp where we have examined 400 patients examination. So when we are doing such camps and we find any such lesion, reduced mouth opening or tongue cancer, oral cancer, we can, as a dental surgeon, we can locate it. So then we should definitely send them to higher center for the proper examination. And another role, as Dr. Asik is telling again and again, role of prosthodontist. Because once a surgeon, oncosurgeon has operated, loss of structure is there, and everything can't be do again by the reconstructive surgery. The role of reconstructive surgery is there, but whatever reconstructive surgeon can't do, that as a prosthodontist, I can tell you, as a prosthodontist, the role of rehabilitation by a device is very important. As we are talking about speech, you know, speech is the articulated with the palate, tongue, and teeth. And once after surgery, this has been lost. The role of prosthesis is there. We can have implant-supported prosthesis. We can have obturators. We can make a fast palate which can produce the sound. So in all these things, the role of prosthodontist is very crucial. And all MDs in prosthodontics are being taught this. And they are doing this kind of prosthodontic rehabilitation. So these are the two crucial roles of all dental surgeons, and they are already in curriculum of BDS and MDS. But as Dr. Kasto very rightly said, if anybody, any maxillofacial surgeon want to do some kind of onco surgery, he must be trained. So this is my suggestion, and we are competent enough to do this for early detection of cancer and rehabilitation part.
Thank you, sir. Dr. Rakesh Gupta, would you like to add to that?
Are you asking me?
Yes, sir.
Okay. Actually, I'm not a dental surgeon. I'm an ophthalmologist, but into public health for long, especially in tobacco control. So since dental surgeons, they are the first point of contact. So each dental surgeon, they must ask about the tobacco chewing habit, especially smoking also, but that tobacco chewing, I think more important as far as the India is concerned. And we in CTCS, because I have recently done CTCS course from ICanCare, so they teach very elaborately how to detect precancerous lesion and the cancerous lesions. So I think that should be part of the curriculum of the BDS and MDS as well. So that will definitely help. And dental surgeons, they definitely have a role in detection of the oral cancers and the cessation also.
Thank you, sir. If there are any more suggestions coming in, how not to miss a red flag, how to send it to a specialist on time, they're welcome. And after that, we'll close this session. Dr. Pawan, you have, I think Dr. DeCruz is there for any final comments, or has he listened to any of these?
Sir, in Dublin Trinity College, they have art as a therapy, music as a therapy. Doctors from London come and give presentation how people with this thing, they just play mouth organ and there is relief in their pain. And they have all the cancer patients, they make paintings and people buy also, and they make potteries. So art as a therapy and music as a therapy. Even in Stanford, I have seen that
Yes,
all
madam. If I may interrupt, I'm sorry to do that. Because of lack of time. There are about 50 plus, about 52 designated cancer centers in the US, and 48 of them have something to do with integrative therapy. Music therapy was introduced at Memorial about 10 years back. We introduced music therapy for our patients 5 years back with specialists. Somehow it doesn't have that kind of acceptance in our patients, and I think that aspect needs to be developed in a more scientific way. But your suggestions are very appropriate, that we must address the patient's need in an integrative and holistic way. That point is well taken. The point which came out towards the last of this panel was that we are addressing the needs of a cancer survivor inadequately at present, and because we are not adequately trained to do that, the people who are primarily involved in curative treatment, these aspects of survivorship are beyond their purview, and those who address those are working in a multidisciplinary fashion at only very select centers. So we need to broaden the footprints of all the supporting specialities. And with that, I would thank everyone. Yes, Dr. Costa, you had something to say.
Just a small comment that, as we saw, prevention, early detection, and treatment, the highest impact will be from prevention and early detection. But both are they need funding, they need cost. There are lots of cost implications. And that's why high risk screening is the key word. And my message would be to do that rather than general public, because we had a very small study, 122 police workers who were taking tobacco. So their doctor screened them whether they are taking tobacco or not, and whoever were taking tobacco were screened, and we could find out 40% pre-malignant lesions, and we could find out 3 early cancers in these 122 people. So what I feel is that when we say that about 60% of adults are using tobacco, and out of this 60, if the detection is done, the rate of detecting malignancy, early malignancy and pre-malignant lesions will be many-fold more than what our general data, which everyone has presented, suggests.
Thank you, Dr. Costa, for those comments. And I would say that we can wind up with the final thought that oral cancer, uh, which Dr. Pawan calls the king of all oral cancer, of all cancers in India, is indeed a public health problem. It so much so that it mandates, and it is a preventable problem, and so it needs screening, a proper screening program, and there are various people. The people who are the points of first contact, primarily oral and dental surgeons, who should have take the onus of early detection and screening. The main impact could be from screening high risk individuals. That's a proven fact, and it's a simple way. Just an oral examination is a very effective way. It's been proven that it can reduce it can reduce mortality from oral cancer just by a proper oral examination. We need to train people in this, and for prevention, we need to train people in tobacco cessation programs, uh, practiced in a scientific way. And for that, we need to reach out to the community, and we need to erect heroes who are successful at this and who can be our brand ambassadors. Thank you, Pawan, Shruti, for giving all of us so much time. Uh, Anil, we were missing you throughout the discussion. If you have any, mostly we repeated what you have been saying all these years. So,
Sumesh, I was following the discussions. I deliberately turned off my mic because I said I would like to hear other people's viewpoints. I had shared my views in my talk, and I had a big time. They were generous to give me 30 minutes to speak. So I just thought, in all fairness, I would like the other panelists to participate. But I totally agree. Wonderful panel. Congratulations to the organizers, to you on your excellent moderation, and to all the panelists for some great insightful thoughts. We have to do something. I leave with one thought. You see, we have about 700 districts in the country. We have 300 dental colleges. If each dental college, when they apply to the Dental Council of India, are given to adopt 2 districts in their vicinity and run screening camps, you don't even need all this high risk screening and things like that. We need innovative thinking in our country to prevent it. And put the government cannot do everything because we don't have resources. But it's up to healthcare leaders such as Kostub, yourself, who influence a lot of policy in this country, to give government good suggestions, and I'm sure they will accept them. So thanks once again, and I don't want to be very long in my comments. Great panel, and hopefully we'll make a dent in the years to come.
thank you, sir. Shruti, over to you.
Thank you so much, sir. I think that's all for the day. We come to the end of the wonderful 4-day program. We had a terrific discussion throughout the day, a very great discussion in terms of hearing all the visionaries, the stalwarts who have been there with us to share all kinds of information for the day. And now with this, I would like to invite Pawan sir, because there was a short video which he wanted to share, followed by Suman ma'am, who can share her comments quickly within a minute, and then we move towards the validatory session.
Thank you. And I think the most important is involving everyone. See, when we talk about the cost can be dissipated when we involve and train the dental surgeons and when they become inclusive of our program. So without commenting further on that, I'll just share the screen and present a video which we have made on the TrisCare instrument. And Shruti, I'm not able to share. Yes, now I'm able to share. Okay. So this is a TrisCare instrument that we made, and a lot of people have been asking me privately about this. So I'll just Thank you for allowing me to showcase this video. And just the good part is that this is now being enrolled or being put in the JAMS and HLL. So it will be available across all the government organizations if they want to have it. And we have been putting this, a lot of hospitals have been asking for this. So and we are shortly starting we are looking for a trial on this with the various groups of various hospitals. So we'll look forward for the doctors who would love to be part of the trial program.